Good afternoon, ladies and gentlemen. It's very good to see everyone that has joined in online. I would like to welcome you to the 111th ECHO session, which is named Recognize, React, and Rescue. This is a very important session because we are going to be looking at things to do with cardiac arrest, which is something that we commonly face in our emergency areas. Now, this session is proudly brought to you by the Ministry of Health, Department of Emergency Medical Services, in collaboration with Seed Global Health. We hope that this will be a very interactive and beneficial learning session for everyone that is online. A brief about what we are going to do is that we are going to have a simulation part, and then following the simulation, we shall then have a discussion around the caveats that we have seen. The objectives of this session, one of them is for us to be able to recognize a cardiac arrest and activate the emergency medical team early enough. The second objective will be for us to do early cardiopulmonary resuscitation, which is good quality. Third is for us to be able to do early rhythm recognition and safe defibrillation. We shall then dive into being able to recognize and address the reversible causes of cardiac arrest. And finally, we'll talk briefly about the post-resuscitation care, which enhances patient survival and good outcomes. Now, before we dive into the details, we would start with some brief introductions of the team. I will go first. My name is Faith Komagum, an emergency medicine doctor from IHK, and I'm also an instructor for Advanced Life Support, European Pediatric Advanced Life Support, and International Trauma Life Support. I will now have the rest of the team come in for self-introductions. We will start with Jonan. You're welcome.
Hi everyone, my name is Ali Jonan. I'm an emergency medical technician working for Kampala Capital City Authority and a diploma paramedic student. Happy to be here.
Thank you very much. Next, we shall have the lovely Mildred.
Good afternoon, everyone. My name is Mildred Nakanjija, and I am a nurse. I work with Rubaga Hospital in the Accident and Emergency Department, and I am an instructor for Advanced Life Support, European Pediatric Advanced Life Support, and International Trauma Life Support with the Association of Ambulance Professionals in Uganda.
And you're very welcome, Mildred. We shall now have the dynamic Dominic introduce himself.
Hi, good afternoon, everybody. My name is Dominic Sanfiongwan. I work with CCARE IHK as the Deputy Head of Nursing. You're very welcome to this session. Thank you.
Thank you, Dominic. Next, the amazing Rebecca to introduce herself.
Good afternoon, everyone. My name is Rebecca Asimire. I'm an emergency medicine resident at the area. It's lovely to be here.
Welcome, Rebecca. Saving the best for last, we shall have Simon introduce himself.
Good afternoon, everyone. Happy to be here. My name is Simon Tumusime. I'm an emergency medicine doctor in training at Macquarie. I'm pleased to be part of the session this time around. So glad to be here. Thank you.
All right, amazing. So we are now going to dive into the simulation scenario. Just to give you a brief background. Before we actually dive into it, we have two other important people that have joined us online. We have Daniel and Sarah. So I will start with asking Daniel to introduce himself, and then we shall have Sarah introduce herself as well.
Thank you very much, and good afternoon, everyone. I am Daniel Olinga, emergency medicine physician and lecturer at Murray University of Science and Technology. I'm glad to be part of this team today. Thank you very much.
Thank you so much, Daniel. It's a pleasure to have you join us as an expert on this session. We shall now move on to have Sarah introduce herself as well.
Hello, everyone. My name is Dr. Sarah Orinawe Charajek. I am an emergency physician based in Yumbe Regional Referral Hospital. Glad to be here.
Thank you very much, Sarah, for joining. Just to have the audience know that Sarah will be handling any questions that you may have in the chat. So if you do have any questions during the course of the session, feel free to post them in the chat and Sarah will do her best to answer them. And for anything that is left pending, we shall have a discussion about it later. Now that we are done with the introductions, I will just briefly give a background about the simulation scenario that we are going to have today. So this case is about a 55-year-old John, and this is drawing from last week, the previous session that we had. John really was admitted for monitoring following a presentation with an SVT that was stable. Now, while on the ward, the patient's attendant notices that John has suddenly slumped and appears to be unresponsive. So she then screams for help and calls for the medical people to attend to John. So that is really the background of what we are going to do. Just watch closely and then we shall have some debriefing after the simulation is done. So Simon.
Yes, please.
As the team lead for the day, I will hand over to you to do what you always do at the start of every day. Talk to your team and do whatever is necessary, and I'll come in later for the scenario.
All right, thank you. Yes, team, let's come in here and then have a small preparation. Yes, good morning.
Good morning.
Good morning, Doctor.
How do you feel?
Very good.
Very good. All right, so today feels like a bright day. Sun is out. We think it's going to be a good day, but just in case, we have to be very prepared. And so we need to sort of identify the role that everyone will be playing in case of any unprecedented emergency that we need to take care of. Okay. All right. I would like for us to identify roles that we're comfortable with. I'll start with you, Mildred. What are you comfortable with?
Yeah, I'm more comfortable with the monitor, and just in case the day goes the other side, I can also do the defibrillator.
All right, thank you, Mildred. So can you make sure that the defibrillator is charged just in case we need it, and make sure the monitor and all the necessary wires are all connected up right? Is that okay? Sure. All right, John, over to you. What are you willing to do?
I think this time round, just in case we have caught or be able to do the chest compressions and help out on the drugs.
All right, so make sure you eat, right? Because we need that energy coming in. Is that okay? All right, and Dominic, what are you prepared to do today?
All right, very good. In the event that things don't go right, I'll be very happy to do chest compressions, but also to do the drugs.
Okay, very good. So Dominic, you make sure that all the drugs that we need are prepared in the crash cut and get all the necessary syringes and everything ready. So just in case we have one, we use that. Is that okay?
Duly noted.
All right, thank you, Dominic. All right, Rebecca, what are you comfortable doing today?
I think I'm comfortable working with the airway today.
Okay, very
Yeah.
good. All right, make sure the equipment that we need for the airway and breathing as well are prepared and are functioning so that when we need them, we can use them. Is that okay?
Yeah, good one.
All right, so we're having a good day, so please let's go back to our shift and keep it like that. In case of an emergency, of follow.
All right.
Come on.
All right, Simon, as you are lurking around somewhere in the ward, an attendant screams frantically, Musawa, my patient is not okay, help me. He's no longer talking.
So when I walk into the room, how is the scene?
The scene is safe because you're in your emergency unit. It
Okay.
looks safe.
All right, so I come with my gloves prepared. So this on quickly. Okay. All right. Okay, I'm going to take care of your how do you call this patient?
Please help me, it's called John, he's not
How old is
talking,
he?
he's not talking, he's 55.
Is John looking at me?
He's not looking, he looks unconscious.
John.
No response,
John,
no response.
Okay, do I see anything in the mouth?
Mouth looks clear.
Mouth is clear? Okay, I'm going to feel for the pulse and look at the chest for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Do I see the chest moving or the pulse? Do I feel a pulse?
You don't see any chest raise, you don't feel a pulse.
Team, we have a cardiac arrest. We have a cardiac arrest.
Right, go here.
Okay, all right. So, Dominic, prepare to take over. So, team, this is John, 55-year-old, that just suddenly collapsed. John, Dominic, I want you to take over on the count of 3. 1, 2, 3. Please take over chest compressions.
Okay, very good, Dominic. I want you to give me 30 chest compressions. Rebecca, please take care of the airway. I want you to give me 2 ventilations every after 30 compressions. Is that okay? All right, you're good. I'd like for you to immediately connect the pad and let me know at what's planned on the monitor. And then Jonah, please make sure you secure the line. Okay.
So the pads connected.
1, 2, 3, 4. So if the pads have been connected, we're going to stop for rhythm analysis on the count of 3. 1, 2, 3. We feel what's the rhythm? Okay, continue chest compressions. We have a shockable rhythm. Over to you, Mildred. Take over.
Okay, so team, I am preparing to deliver self shock. Everyone else clear apart from the person doing chest compressions, please observation. I am selecting maximum joules. I'm charging. Everyone else clear apart from the person doing chest compressions. Dominic, when I say stop, you will stop chest compressions. Stop chest compressions. Shock delivered. Resume chest compression.
Right, well done, Mildred. This is our first shock. Okay, so Tim, we have 2 minutes to address the reversible cause of shock. Rebecca, immediately I want you to please put an eye gel and then connect to 100% oxygen, 15 liters, yes. And then for Jonan, please secure 2 lines. I want you to give me 1 liter of IV fluid as soon as possible. Is that okay? Okay. And also take off samples for electrolytes and RFES for blood glucose. Is that okay? Okay, Doc. Okay, Rebecca, let me know as soon as you're ready.
Yes.
Okay, Doc, I've secured 2 large bore cannulas. I'm running fluids. I've taken off lab samples and I've sent them to the lab.
Okay, so we've addressed our hypovolemia.
Yes.
Do we have our electrolytes?
They'll be out in about 5 minutes.
Okay, and how about the blood pH?
RBS finger prick is 6.5.
So we go there. Rebecca, you ready?
I've inserted the eye gel.
All right. So do continuous ventilation area for 6 seconds. I'm going to alternate.
You have good air entry. Good air entry.
All right, very good. And it's connected to 15 liters. Okay, very good.
Connected to 15 liters.
We've addressed hypoxia, we've addressed hypovolemia. Make sure you cover the patient to address hypothermia as well. Is that okay? Okay, very good.
Please allow 15 seconds for balance to check.
All right, so Dominic, I want you to prepare a switch over with Jonan. Jonan, when I say Dominic, when I say stop, you stop chest compression. Jonan, when I say start, you start chest compressions.
Okay.
We're going to prepare for rhythm analysis on the count of 3. I'm feeling for the pulse. 1, 2, 3. Stop for rhythm analysis. Continue chest compressions. Okay, so we have a shockable rhythm. Over to you, Mildred, for a safe shock.
For the team, I'm preparing to deliver safe shock. Everyone else clear apart from the person doing chest compressions. I am selecting the maximum joules. Charging. Everyone else clear apart from the person doing chest compressions. Please off the bed of the patient. Don't hit when I say stop, please stop. Stop chest compressions. Shock delivered. Resume chest compression.
Okay, very good. All right, so we have another 2 minutes for our next rhythm analysis. In these next 2 minutes, we're going to address our reversible causes of shock. So reversible causes of cardiac arrest. In the
Excuse me, this was our second shock.
Okay.
Please, I suggest let's prepare medications in case we have a third shock.
All right, thank you, Mildred, for that reminder. Dominic, could you please prepare 1 milligram of adrenaline in 1 in 10,000, as well as a milligram of 300 milligrams. Is that okay?
All right.
All right. In the meantime, I'm going to check for tension pneumothorax. Rebecca, do you feel any resistance when you're back?
I do not feel any resistance.
Okay. Do I hear air
Good
entry?
air entry. Good air entry bilaterally.
Okay. And what's the percussion?
No more resonance. No more resonance.
How about the?
Trachea is central.
Okay. So we don't have tension pneumothorax. Do we have a toxic screen?
A toxic screen is going to take a bit longer, about 15 minutes, but the nurse that was checking his records says that there is no history of drug use, and also based on his history, there is no likely cause of intoxication.
Okay, very good. Do we have focus available right now?
We do have focus. It was in use in the ICU, but the team can be notified to rush it down to the ED.
All right, so we need focus for to check for cardiac tamponade as well as for pulmonary embolism.
Team leader,
Okay.
adrenaline 1 milligram ready, and amiodarone 300 milligrams ready.
Well done, Dominic. All right, so Mildred, how much time do we have?
10 seconds, one explanation.
All right, thank you. So, Jonan, you're going to prepare to switch over with Dominic on the next rhythm analysis. Jonan, when I say stop, you stop chest compressions. Dominic, when I say start, you start chest compressions. I'm going to feel the pulse as we do a rhythm analysis on the count of 1, 2, 3. Stop for rhythm analysis. All right, resume chest compressions. This is a ventricular fibrillation, a shockable rhythm. Mildred, over to you for safe shock.
Team, I'm preparing to deliver self shock. Everyone else clear, apart from the person doing chest compressions. Selecting the maximum use. Please don't let off the patients. Apart from those who is doing chest compressions, I am charging. I'm charging everyone else clear off the beds. And Dominic, stop chest compressions. Shock delivered. Resume chest compression.
Well done, Mildred. This is our third shock. Jonan, immediately please give adrenaline as was prepared by Dominic. 1 milligram, 1 in 10,000, as well as immunotherapy milligram. Make sure you give a bolus immediately after every drug and lift up the heart. Is that okay?
Okay, Doctor.
Okay. In the meantime, we're going to go through our reversible causes of cardiac arrest one more time. I'm going to start by checking for hypoxia as well. Connected to oxygen.
It's connected to oxygen.
You feel any resistance with
I
your
don't feel any resistance when I bar.
Good air entry bilaterally.
Okay, I'm also going to check for tension pneumothorax.
No more resonance, no more resonance. Trachea is
All
central.
right, so we have adverse hypoxia and there's no tension pneumothorax. In the meantime, what's Jordan, you want to tell me something?
Yes, stimulate given adrenaline and amiodarone are fresh. We have raised the liver.
Okay, very good. So also make sure you now put another line. I want you to give 500 mils of normal saline one more time. Is that okay?
Already
All
ready.
right.
The lab has some result for you.
Yes.
They have the electrolytes back. Your potassium is 4, sodium 140, chloride 100, calcium and magnesium are all in normal range. So we don't see anything that could be alarming.
So electrolyte panel is good, and now that glucose was also good.
Yes.
How far with the focus?
So the focus is just at the doorstep. They are almost arriving.
Almost arriving,
Yeah.
but and then the toxicity was negative.
Yeah, we don't
Okay.
have any.
Right, so Mildred, how much time do we have?
We have 5 seconds and it's to the
Okay, very good. 5 seconds. So Dominic and Jonan, please prepare to switch over during the next rhythm analysis. Okay, Dominic, when I say stop, you stop chest compressions. And Jonan, when I say start, to start chest compressions. I am going to feel the pulse as we do the rhythm analysis on the count of 3. 1, 2, 3. Stop for rhythm analysis. Team, I see a rhythm compatible with life.
Nice.
I can feel a weak pulse. So team, we have return of spontaneous circulations. Well done. Rebecca, please disconnect the back. Let's see if there's any spontaneous breathing. Let me know.
On assessment, the patient is not breathing spontaneously.
Okay, all right. So Rebecca, continue ventilating. We're now going to get prepared for post-resuscitation care. Is that okay? All right. Well done, team. Let's continue the show.
I'll end the scenario here, team. Over to you to do the debriefing.
Okay, well done, Tim. Now we've done our post-resuscitation care. The patient has now been transferred to the ICU. We have some time. We're going to do our hot debrief, and then we shall get prepared to do our cold debrief much later. Is that okay?
Yes.
In this hot debrief, we're just going to find out if there are any real issues that were there that we need to address right now. Otherwise, the rest will conduct during the cold debrief. To start, we had a 55-year-old gentleman, John, who suddenly collapsed. I immediately went to intervene and found that he was in a cardiac arrest. I started CPR and I called you and you came in there. So can we recall, were there any challenges or any issues, or how did we perform as a team?
Yeah, I feel we performed well. First, team leader, you did well. It was totally out of the but we did well.
Very good. Thank you, Mildred. All right. So we'll try and make sure we carry that forward during the next scenario if that comes. Rebecca, do you have any comment?
I really love that we had really good close group communication. If
I-
someone did an action, they were able to communicate back.
Very good. I really like that because I knew what was going on at every single point. Is that okay? And I think we're going to carry that forward. That's a very good thing. And then Dominic.
All right, I think everyone did their best. That's why we have Ross.
Yes. Thank you, Dominic. I know it was very stressful, but we'll make sure next time we get you something to stand on so that you don't get tired easily. I recognize that as a challenge. And then Jonan.
I want to appreciate Mildred, the person who was on the DPIP. She really made sure that she was delivering a safe shock.
Very good. I also like that she reminded me when I had forgotten that this was a third shock, a very important Mildred, because we are all collectively responsible for the patient. And I think I appreciate you all. So let's go back to our respective duties. We'll come back again. Please have something to eat, Dominic. All right.
All right, thank you so much, team. So this is it for the demonstration. Now we shall go into the first poll question, and then we shall see what it has for us. So the first poll question says that we have a 45-year-old man who collapsed suddenly in a market. He is currently unresponsive and is not breathing normally. The paramedic team was very responsive and arrived within the first 5 minutes, which means by the time they arrived, 5 minute mark had not yet been hit. So what do you think is the most appropriate action to do immediately at this point? Let's see some of those responses coming in. I can see that a lot of people are responding already. Wonderful. Please tell us your thoughts. We shall have a discussion at the end of the session about what the correct answer is. Okay. All right, so thank you to the people submitting responses. We would like this to be as engaging as possible, so please keep your thoughts coming in. And for anyone who has questions about the simulation, about the scenario, any technical questions, please post them in the chat. We have experts ready to answer your questions. And we might also have a moment later for you to unmute. Okay, we still have a few more people left to fill in their thoughts for the poll question. Please answer the question. We only have a few more seconds before we end the poll. We have more than half of the participants responding. Can we have some more responses quickly? Lovely, thank you all for the engagement. Let's keep the answers coming through. All right, so we are going to end the poll session here, and we shall revisit these questions later and then talk about which answer is correct and why it is correct. Okay, so right now I would like to delve into a brief discussion with the team. Team, that was quite amazing. You know, I really enjoyed how you managed the case. What really stood out for me as an individual was the preparation at the start of the day. It's something that's very unique and something that a lot of us can learn from. So thank you for the brilliant teamwork and communication. It was really amazing. Well done to the team. Right, so I would like us to go into a few, discussion points, because these are real life situations that we face every day. And it's important that we understand that emergencies start before the emergency unit. So sometimes this might happen out of hospital. And so I would like to start with you, Jonan, being one of the people that's always the first on the scene, the one that's responding in those uncontrolled environments. What are some of the earliest signs you would say in the pre-hospital setting that you think the providers in the pre-hospital space should be able to recognize?
Okay, thank you so much, Dr. Faye. I'll take it, I'll answer that question following our anthem of A, B, C, D, E. So some of the earliest clinical signs and that could alert me that this patient could be going into a cardiac arrest. In my airway, I want to look at this patient, observe in case there is any obstruction. This could be the tongue, in case my patient is unconscious. Maybe there could be a sound like snoring. In case there are secretions, that could be like gargling. And then in breathing, I want to assess my respiratory rate. In case the respiratory rate of my patient is below 10, starting 11, then I'll be worried. And that will call in for assisting that patient, maybe by bagging. I need to breathe for my patient. In case the respiratory rate is high, that means I need to supplement with some oxygen. Then in C, I want to look at my patient in case my patient is going into shock, any signs of shock. So I'll start with a cup refill in case it is delayed. If it is weak and it is lower than 60, I will have to keep monitoring my patient. And then also I look out on the skin. Then in disability, I want to assess for response level of consciousness using my AVPU, the alert, voice, pain, and unresponsiveness. And in case my patient scores a U, that is unresponsive, that means that I will be worried. That is also an eye sign. Then also I want to check my RBS in case it is low. That will give me an alert that my patient is in a hypoglycemia, which will really be an alert that I need to monitor my patient. Then lastly, that is E, which is exposure. In case my patient's temperature is low and is maybe cold, that will also give me an alert.
That's a wonderful response. What I really like pick from your discussion points are that somehow that also drives us into the causes of the cardiac arrest. So things when you're talking about like your airway obstruction, your breathing difficulties, they're going to drive us into hypoxia. Your exposure issues will drive us into hypothermia. So somehow that is really like the most critical thing, and it's important to recognize these things early and prevent the cardiac arrest from happening in the first place. Thank you for sharing those amazing thoughts. Now, following up to that question, what, from your perspective as a paramedic, what are some of the critical actions that can be taken in the pre-hospital space? I know you have mentioned some of them, but just to have them come out more clearly, what are those critical actions that you would take specifically in that pre-hospital phase to be able to prevent a cardiac arrest? Now that we've identified the early signs that could lead into it, what do we do to actually prevent that from happening?
Okay, thank you so much. Still following our anthem as EMS, we shall always follow the ABCDE in managing, in assessing. So still I'll have to start with my airway, and I will have to, in case there is some secretions, I have to sanction my patient. I can position my patient, and in case I have access to agents like OPA, that is oropharyngeal airway, I will have to insert it because it will help me to maintain an open airway. Then going to be, I'll have to support my patient with oxygen. As I earlier said, in case the respiratory rate is high, that means that my patient is having a respiratory distress. I need to supplement with oxygen. Then in case the respiratory rate is low, that means that my patient can't breathe. So I have to breathe for my patient by bagging. And in C, in case there is any external bleeding, automatically I have to control the bleeding from the start. And then I can secure large bore cannulas to run my fluids. And then running to disability, where I will have to take my RPS, and in case it is low, I'll have to give dextrose, giving glucose. Trace it. Then in exposure, in case the temperature is low, I'll have to cover my patient.
Amazing thoughts there. Thank you so much for sharing the pre-hospital perspective. That's very enlightening, and I'm sure a lot of people can learn from that, because the first step in the chain of survival is actually early recognition, right? We want to prevent the cardiac arrest from happening, and you've given us some very good insights from that space. So at this point, we shall go into our second poll question. So please watch your screens, and we do encourage you to be as engaged as possible. Share your thoughts as we go into that. Right, I can see the chat is busy, but I'm quite confident that our EM physician, Sarah Oworinawe, is handling the questions adequately. So anyone with questions, keep posting them into the chat. We'll be happy to respond. Yeah. Right, so we have a question displaying now. Question 2 regarding our poll for today is, we have a patient in cardiac arrest who arrives at the ED. Now the assumption is that CPR is already ongoing and has been commenced, and the monitor shows ventricular fibrillation. So what do you think would be the immediate next step for you to take? We'll have that display for a bit more time. We have people responding. We're happy to see your responses. Please keep it going. Okay, we have almost half of the people have responded, and the answers are quite interesting to see. So let's keep it going. So that there are 4 options here. Do you want to administer epinephrine immediately? Do you want to begin your advanced airway placement? Would you like to deliver defibrillation immediately, or is fluids your priority? So let's see your thoughts, and we shall have a discussion about this a little later. Yeah, so think about the chain of survival, think about what you want to do next, okay? The assumption here is that the patient has arrived to the ED, CPR has been commenced, and now you notice that there is a shockable rhythm, ventricular fibrillation. And we'll also keep the questions coming in the chat. Okay. So thank you all for the responses. We shall end the poll for now. And don't worry, we'll come back to discuss what the right answer was and why. For now, we shall dive back into our debrief and discussion. We are now going to transition from the pre-hospital space into the hospital space. And with that, I would like to get a nursing perspective on this. So Dominic, could you just let us know from your perspective as a nurse, what would you say defines high quality CPR, and what are some of the common errors that you've observed during resuscitation that you would like to share with everyone?
All right, thank you very much, Dr. Faye. High quality cardiopulmonary resuscitation is when we are able to mimic what would have actually happened in the normal function of the cardiopulmonary system. And we will define the high quality CPR in this line when we are able to offer adequate chest compressions. For example, if you have a patient that has had an arrest and they are an adult, you expect to deliver between 100 to 120 beats per minute of chest compressions, and they must be adequate in that line. If it is too slow, then definitely we're not perfusing enough. If it is too fast, then we're not allowing the heart to fill again, so that then we can be able to compress the blood to the rest of the systems. Number 2, there should be a correct depth to the compressions that we're delivering. In that, between 5 to 6 centimeters would be adequate for an adult, and this would provide sufficient cardiac output and also improve the coronary perfusion pressures, so that at this particular point, then we are able to mimic what would have happened in the normal cardiopulmonary function. We also ought to allow the chest to recoil. Again, like I said earlier, we should allow for complete release of pressures on the chest. With every compression that we deliver, this will aid venous return. It will also aid, again, filling of the heart so that we have enough volume to deliver to the rest of the organs. Number 4, we should limit on interruptions. If we must have an interruption, then it should be for less than 10 seconds. Like we saw in the simulation today, the team endeavored to ensure that the chest compressions were within at least more than 60 to 80% of the fraction of the time that we spent resuscitating the patient, meaning that at all times, we should be able to limit interruptions as much as possible. Again, this will enable us to aid the patients to have a better chance of recovery. Proper ventilation is another point. Again, referencing to what we've just had, hyperventilating patients it's usually very easy to hyperventilate them because of the adrenaline rush that is happening to the team. But we ought to ensure that if we already have an advanced airway, we continue with the continuous compressions, but also continuous delivery of the breath. And at this point, we're ensuring that we're not hyperventilating the patient, but we're just delivering what is good enough for them. For example, maybe between 10 to 12 beats per minute in the entire period, so that, again, too much of everything is always not the best. Next, number 6, we should ensure that we have a proper positioning of the hands as we compress the patient. We know that the lower third of the sternum, maintaining the midline, is very important. We keep the arms straight and the pressure is coming right from the shoulders, so that then the elbow is not bent, but rather it is straight, and the compression pressures are coming right from the shoulders. And so we're delivering an efficient kind of compression to the patient. And then most important, again, is that as we do cardiopulmonary resuscitation, we should ensure that we have early defibrillation. Now, in events where we have patients that have shockable rhythms, again, as we'll discuss later, it is very key and very important, like we demonstrated in a simulation today, that we deliver the shocks adequately and at the earliest opportunity, meaning that the first respondent, when they come in and they call for help, the AED or the defibrillator must be availed within the next 2 minutes. And during this period, we should ensure that we have delivered the shock. If the patient had, for example, a ventricular fibrillation or a pulseless ventricular tachycardia, and these must be done in a safe way. Just like we depicted today, we were able to see very cardinally that it's important for the team to work together. It's also important for the team to protect each other during the provision of these shocks. And then finally, CPR cannot be done without team dynamics. We have a group of people that are doing different things, but all those different things are intended to save the patient. All those things are intended to give us a ROSC at the end of the day. So we must have a team leader that distributes roles effectively. And also we must have a team that has a closed loop kind of communication. When adrenaline is given, for example, it should be verbalized that 1 milligram of adrenaline has just been given, so that the team leader and the person scribing the notes takes particular notice of these things, and then we don't have to repeat them as the code continues. However, it's not unlikely that errors occur. It's usually a very tense situation where we're having different members of the team having different levels of experience, having different levels of calmness. And so because of this, errors are always and always present. I'll present next the opposite of what I've just discussed, will depict the key issue that we can face when we're delivering cardiopulmonary resuscitation. Inadequate compressions can be either too shallow, or it can be too deep, or it can be too fast. Oftentimes, people fear that we are at risk of maybe rib fractures, but you would rather stay alive with broken ribs than go to the grave with your ribs intact. The compressions could be very slow, less than 100 beats per minute, or more than 120 beats per minute. Again, like I said earlier, We want to mimic the cardiac function, we want to mimic the respiratory function in this time, because it is key that we are able to provide perfusion to the patient and also able to save them in the long run. Many a times we want to compress the chest without allowing it to recoil. We usually lean over and apply all the pressure onto the chest and not allow the heart to feel again. Remember, it's just about 10 to 30% of the perfusion volume that we're able to circulate during this process. And so if we are unable to allow the chest to recoil or allow the heart to feel again, then it is of disadvantage to the patient, because then we are just circulating very little volume of blood and therefore will not be able to attain the kind of perfusion that we require. Excessive interruptions usually can happen. Give scenarios where the airway is a bit difficult and then we attempt several times to get an advanced airway. This, if they happen, then they are not called for at that particular point for as long as we're able to continuously ventilate the patient. If a person that is skilled enough to have maybe a single or double attempt is not there, then it is important that we continuously ventilate the patient, but ensure that we limit on the interruptions. Another place where we interrupt a lot is usually during the pulse checks, during the rhythm checks. Somebody will try to figure out, what rhythm is this? And then it takes us a full minute. It is usually not called for. If we can't identify it, then we need to continue, because it's very important, again, that we maintain the fractions of compressions to be at least 60 to 80% of the entire period. It can be a very difficult IV access. So we struggle to get IV access and spend a lot of time to just try to get access. And again, we can use other avenues that we have available. We can use an interosseous line if we can have access to that. Usually much easier if the equipment is available. If it's unavailable, we can often improvise to ensure that we're still able to provide the required drugs and the required volumes to the patient. In other circumstances, like I depicted earlier, hyperventilation is usually a problem. Now, the moment we hyperventilate the patient, we increase intrathoracic pressures, and all these will compromise on venous return. We'll have reduced coronary perfusion pressures, and so we're not able to attain the goal of the resuscitation to have a ROSC at the end of the day. So another thing, usually maybe you come to a facility or come to a place where no one knows how to use the defibrillator that has been bought. Because JMS supplied the defibrillator, nobody has learned how to use it. So we spend maybe a couple of minutes trying to figure out, where do we put this electrode? Where do we put this? How do we shock? Again, all these delays are very dangerous, especially if it's a shockable rhythm where we must act within the first 2 minutes. The other issue could be poor team dynamics. I have seen this many times where you're having several people offering several instructions that are not aligned. For example, somebody says give adrenaline, another says no, give sodium bicarbonate. Now, the entire team is confused. The entire team does not understand the kind of direction they want to take. There's lack of role clarity. Nobody knows what to do, when and how. And in the long run, you realize that the entire team is roaming around, they're moving, but there is no particular activity that is going on. And there's decision fatigue that keeps happening to the team. So these errors often happen, but as we continue to have such sessions and simulation exercises, I'm very sure that we are able to address them and reduce them to bare minimum so that we enhance the chances of return of spontaneous circulation to our patients. Thank you, Chair.
Wow, Dominic, that was really, really amazing. You've given us some wonderful insights and you've left no stone unturned, really. I'm very thankful for the way you have explained the reason behind. A lot of the time people just hear, oh, good chest recoil. You need to go deep. You need to do this number of compressions in a minute. But I think it really drives the point home when you explain what the action is doing to the body and how that is going to improve the outcome of the resuscitation. Another important thing he did mention is team dynamics. These are some things that are really underlooked, but really the success of resuscitation a lot of the time cannot be positive if the team dynamics and the non-technical skills are not emphasized enough. So that is something that training and drills and sessions such as this give us insight on, and I hope that a lot of people have learned from how the team was coordinated during this response. The other important thing is to know the equipment. That was very interesting to me, that you might have something like a defibrillator, but you've never turned it on. You don't even know if it's charged. You don't know how it works. So these are some of the things that we have to think about moving forward. So that was really very interesting to hear from the nursing perspective. And just to follow up on Dominique's points, I will now move over to Mildred to tell us her perspective still as a nurse. Now, what I would like you to tell us is the role of nurses really during CPR and maintaining the good quality monitoring and resuscitation. What is the core role of a nurse in this high pressure situation?
All right, thank you so much. Yes, most of the things have been mentioned, but I'll just I would draw more light, especially on the qualities of good compressions, the role as a nurse, what I should do. One first thing is absolutely you should know what high quality chest compression means, which they have already mentioned. So at the back of your mind, you should be knowing, oh, am I able to achieve 100 to 120 compressions in a minute, you as a nurse? So if you're not doing it, get to know that I am not giving high quality chest compressions. Then what else? Please, communication is very key in maintaining high quality chest compressions. Don't wait for your team leader to tell you, okay, can you please switch? The moment you feel like you're not able to deliver, please communicate. Team leader, may I have change of chest compressions? At the end of the day, you're giving us the high quality chest compressions that we want. Then you have to, foretell. You're providing high quality chest compressions. The patient is on the bed is higher than you are. All your height, I don't want to mention that. So you really have to predict, and then you make a decision. So am I able to provide the high quality chest compression? So please predict, make a decision. Okay, let's maybe lower the bed. Let's put the patient in a comfortable position for you to provide high quality chest compressions. Then the role we play in resuscitation or maintaining it. So I want to put this, resuscitation basically doesn't mean we are in a cardiac arrest. That's not only resuscitation. So it can be you're seeing your patient, like how my colleague John had said, things that he can look at, and he tells this patient is going to go into a cardiac arrest. And then there is that time during a cardiac arrest and then after. So what roles as nurses do we do to make sure that we are doing this to our best? So the first thing is, in the monitoring bit of it, you really have to have knowledge about the early warning scores. Those you have to be knowing your vital observations, and we still use the song, the EMS song John had mentioned about the ABCD. So as you're monitoring your patients, following your ABCD approach, there are certain things you would see, and you have to take an action, all according to whatever guideline to be following about the early warning score. You're seeing your patient's early warning score is beyond the normal. Please don't sit as a nurse and be like, okay, let me wait for a doctor to come and review my patient. Please take a step in that something can be done, either if your patient is on ward, is moved to HDU, or a decision is made to move to ICU. So that is your role, and in that process, you're helping us maintaining good resuscitation if we need to do, because we've gotten high early recognition, all right? So it is very, very vital for us as nurses to recognize early. Before, even during the time of a cardiac arrest, immediately you've recognized, start your high quality chest compressions that we have learned. Don't just run away, because we have appreciated that early recognition and high quality chest compressions, your patient is going to achieve. Your patient is going to benefit more, sorry. So please immediately start high quality chest compressions, all right? Then during in case we've gotten now a cardiac arrest, your role as a nurse, one, documentation is very key. It's very, very vital and it's important. You really have to document. So please, if you're assigned to that role of documentation, don't feel like I have a lot of energy to do chest compressions. I have a lot of energy to do. We need you there. It is very important in documentation because during that time, everyone is under an adrenaline rush. They could mention something, you start to argue, you're wasting time. But if you've documented at this time, we have given adrenaline, this amount, this milligram, we have done this. It is very, very key for us to document, right? In that process, it's going to help us check ourselves, actually, in case we are doubting what we did to the patient. So it is very key and it will always help us maintain or achieve good care to our patient. Yes. And then the other points that we do that help us in our resuscitation as nurses, maintain it or keep it very key is the team dynamics and the communication. It is very, very important. Please don't, they have assigned you a role, assuming you're on the airway, just because they told you be there. You're like, okay, I am there. You literally do not know what you are doing. Please communicate back to your team leader. I think when we started, Simon mentioned, what are you comfortable with? It's not just a mere check. It's something that is very key because it will help us achieve the quality of resuscitation that we want to this patient, right? Yes.
Wonderful.
Yeah, there are very, very many other things.
Yeah, please
Right.
go ahead.
All right. So what are the other things we can do to maintain this? I want to talk about the issue of cross monitoring. What do I mean? Cross monitoring is you are given you've been given instructions. Please monitor this patient's RBS every after 1 hour. Or please monitor the blood pressure every after 30 minutes. It's not just because they want you to be busy or they want you to always be on a patient. It is very important. Reason being, there is a target you would have achieved in that particular period of time. So if you're told to do the blood pressure every after 30 minutes, please do it. There is a reason behind. We want to see if we have achieved the target we want. In case we have not achieved it, another step is being taken. And this will help us initiate our care or improve our care early enough, right? So please, cross monitoring is very key and following whatever instructions you have been given or what you know as you, right? So it is very key to carry out cross monitoring as instructed or as you know, right? Then the other important thing in a resuscitation medication, administering medication the right way. We know nurses out there, you know those rights, the rights when you're giving injections or medication, the rights you should do them very well, your right patient, your right time. So it is very key, the right dose. Please don't compromise a patient's dose because you don't want to move somewhere like, okay, they have told me to give 1 liter. I am lazy. I'm tired anyway. I'll give the 500 mils in an hour's time to come. You've been told to give it within maybe 30 minutes. There is a reason behind it. So we should, in this, what I want to emphasize, we should be knowing the rationale of each and everything we are doing. Meaning this will help us achieve good resuscitation in case you're doing it. So please, medication at the right time, it is very key, it is very, very important. And the right dosages, please inquire if you do not know. And it's like there is nothing wrong in asking if you're not sure of whatever you've been told to do. Yes.
All right, wonderful. Thank you very much, Mildred, for that insight regarding the nurse's role when it comes to good quality CPR, when it comes to monitoring as well. I think I would like to just draw from your point regarding medications, these are very, very important. So I realize that's also a place where there can be a lot of errors in terms of the concentration, in terms of making sure the drug you are giving is right. So it's very important. And nurses are always very skilled with helping us like really double check and make sure we are giving the right drugs and at the right time, which also comes with the documentation. So like you said, it's very important. And I was thinking about it. Part of it comes from nurses will be able to remind the team that, oh, wait a minute, we are on shock 3 and we have not given a drug yet. So if we are not documenting, there is no way that we shall be able to recognize that we have missed out something. So thank you so much for sharing those insights. At the moment, we are going to go into our third poll question now. And I would ask you to look at your screens and really answer the question as you feel fit. And then we shall discuss them towards the end of the session. So question number 3 is really about reversible causes of a cardiac arrest. So the question reads, which of the following is one of the reversible causes commonly remembered in the H's and T's? So look through. We do know that there are 4 H's and 4 T's of cardiac arrest. So this is a bit of a trick question. So what do you think is a reversible cause from the options that you have? We do have hypertension listed, hyperglycemia, hypoxia, and hyperlipidemia. We would love to see your answers and your thoughts to this question. Okay. Right. The H's and T's. So in terms of the H's, which of these is a reversible cause that is commonly remembered? Okay, let's keep the responses coming and let's keep the chat active as well. Okay. We do have the chat busy. We have some questions around rhythm checks, using a defibrillator, when to give up on compressions. Okay, someone is saying something about closed loop communication being key. That is very true. So let's give answers to the poll, and the questions in the chat are going to be addressed by Dr. Sarah in a moment. And some of them will be covered during the presentation, but if that is not done, we can always have another Q&A at the end. All right. Here, just a few more answers, and then we shall close the poll. Okay, so we shall end the poll here for now, and we shall revisit this in our discussion at the end. For now, we are going to move on from the nurses to the doctors, right? The emergency medicine doctors now. It's your turn to give us a bit of insight into how it is on your side of the arena. Now, I'll start with Simon. Simon, could you briefly tell us what are some of the reversible causes that you commonly see in your settings that lead into cardiac arrest?
Thank you, Faith. That's a wonderful question. I wanted to say that the forces to lead a cardiac, I just wanted to say that it's not just emergency medicine doctors that can lead a successful CORD. That anyone who's trained can be able to lead one. There is an algorithm that we use. I know it builds onto a number of sequences that you have to perform. And for a patient that hasn't yet had a cardiac arrest, Jonan explored what an ABCDE would look like. But for someone who has a cardiac arrest, there are sequences of actions that we try to follow that I encourage everyone to follow. But specifically to the question that you've asked me, the reversible causes of cardiac arrest. There is a common mnemonic where they are characterized as the 4 H's and then the 4 T's. The 4 H's centered around, you start with, there's hypoxia, there is hypokalemia, hyperkalemia, so you're having electrolyte imbalances. And then you have hypothermia, hyper, and then the other one is hypoglycemia. So those are the 4 H's. And then hypovolemia, I think, yes, which I left out. Those are the 4 H's. So the hypoglycemia, the metabolic ones are all centered around the 1 H, and then hypovolemia is the other 4 H. And then the T's are, you have things that have to do with thrombosis. So now you're looking at coronary thrombosis or pulmonary embolism, which is not always easy to find coronary thrombosis within the cardiac arrest, but it's possible. And then you have the other reversible causes, tension pneumothorax. You have toxic screen. Certain toxins can easily lead to a cardiac arrest. So it's really important to have your toxic screen done. And then the last one is cardiac tamponade, which is also very critical. Now, I wanted to go further. I don't know if you'd allow me to sort of highlight how those can be tackled within a cardiac arrest sequence. Typically, there's priority of actions during the cardiac arrest algorithm that I think the team together managed to do as a whole. So the way we go about that, we can start with the H's alone and then address the T's alone later. And then later on, you could try and make sure you reassess them. Because it's a cardiac arrest, and this is a common mistake that I see very many care providers do, is that during the cardiac arrest, many people rush to put a blood pressure machine, right? Some people go ahead to check for pulse
saturation.
It's a very common
I've
mistake.
seen that as well.
But and then you sometimes you ask yourself, do they understand that this is a cardiac arrest? And everything that they're going to read, if it's probably going to be because of the compression. So there's no role, and I should say this, there's no role for checking for vitals. I know many people in our setting prefer to check for vitals to then react. So it's only your clinical assessment that is going to guide you in this approach. Now, when it comes to the reversible causes of cardiac arrest, if you start with the H's, hypoxia, when you most people would then, instead of hypoxia, they would go to check. There's no role in checking. We address hypoxia because we know it's one of the reversible causes. So how do we address it? And I think if you notice as a team how we're going about this in the algorithm is we made sure that the patient had, first of all, the airway was clear and patent. And I think Rebecca did a good job to make sure that we have initially secured with an airway adjunct, OPA, and then later on moved to an IG, which allows for continuous ventilation with uninterrupted chest compressions. So that makes sure that every oxygen that you give through ventilation gets to the patient. The other one is to make sure that that patient is getting oxygen from your ventilator bag is connected to the oxygen, right? So that's another mistake that some people make. The bag valve mask that many people like to use does not manufacture oxygen. That oxygen comes from the wall. So it does allow you to provide some oxygen while you provide, but really that oxygen comes from the atmosphere, which we know is about 21% and is never sufficient in a cardiac arrest. So as a must, whenever you have oxygen, make sure that patient's valve mask is connected to oxygen, preferably make sure it has a reservoir as well, because that makes it easier to then provide as much oxygen as possible. So that's how we address hypoxia. We make sure that the airway is patent. We also make sure that our oxygen is delivered and it's connected. So that's how we address it. There's no room in checking. And then we move to hypovolemia. We know hypovolemia is one of the causes. So the approach is we're just gonna give fluids, right? So we typically start with 1 liter, and then when reassess, maybe we can try 500. But as a reversible cause, we know hypovolemia leads to shock, and shock can also cause a cardiac arrest. And so we give, there's no role in checking the blood pressure at this point. And then for the electrolytes, you can take an arterial blood gas. You can also take you can take some samples that can be run, and then you know the electrolytes. The most common culprit among the electrolytes is the hyperkalemia, because then it needs to be addressed in a certain type of way, which I won't go into a great detail. And then lastly, if there is a hypoglycemia, you make sure you also give blood sugar. And finally, if hypothermia, make sure you cover the patient, which in most cases would be the case. So you make sure that the patient is covered. So that's how you address your H's. Check again with the person who's keeping time, so that then the priority would be to check the rhythm, and then during the next 2-minute cycle, you can then go through the T's systematically. So we did the same thing. For the T's, the very first one is the tension pneumothorax. So there's a difference between a pneumo and a tension. So we make sure we identify things that would tell us this is a tension in this case, because the treatment would be to try and put a needle, or for instance, in some cases have to put a bilateral finger thoracostomy or put a chest tube. But in this case, you have to first confirm. So how do we confirm? If you noticed, I did ask Rebecca if she was feeling any resistance, and that would happen if there was a pressure buildup in the chest. So every time you ventilate, there will be a small resistance, and that resistance will keep on increasing. That might give you an idea that you might be having either barrel trauma or some form of tension pneumothorax that's already built up. The other way is to auscultate, as the person who's giving oxygen or who's ventilating, you'll be able to hear air entry, breath sounds on either side equal. That would give you good reason to think that there is no pneumothorax or there's no tension pneumothorax. And then lastly, you can percuss and then make sure you feel the trachea, that it's not deviated. So that's how you would address the tension pneumothorax. I mean, that's how we suspect. And then if it is from any of your findings, you can then proceed to do finger thoracostomy or a needle decompression urgently. And then for the tamponade and thrombosis, specifically pulmonary embolism, it's not always easy to identify, even with a skilled person clinically. So the goal is to use point of care ultrasound, which I think is becoming a big thing in our setting, and is really necessary, because so that's why in our case we had to ask for one, because we needed to sort of identify it's a tamponade. Are we dealing with a pulmonary embolism? Because then we can start the treatment. And then finally, the toxic screen that I said gives you information on what kind of toxins are you dealing with, and sometimes we have antibiotics that can help address them. So mainly, in a summary, in a nutshell, those are the reversible causes, and that's how we sort of address them. I just have to put lastly that the way we approach the reversible causes in a patient that is not necessarily trauma are very different from how we would approach them with a trauma patient. So that is something that we might not be able to cover here, but it's important for you to know as a team that the reversible causes might still be the same. The priority is a little bit different in trauma, and the sequences of actions are also quite different. But in a nutshell, those are the 4 H's and the 4 T's. Thank you.
That's very wonderful. That's amazing. I really have not much to add. That is it from the doctor's side about the reversible causes. I think just to supplement a little bit there is that in all patients, a little bit of history goes a long way. So it really will help you to prioritize these causes. As Simon said, if it's a trauma patient, you will know that there are certain things you should prioritize, and then you can also check the rest. If the patient maybe was is like a drug addict, there's certain things you'll think about. So there are really there's really a huge role for getting some history as well. So if you have a big team, someone can go on the side and do that as well. So that was really amazing. Now I will move to Rebecca at this point. So Rebecca, how about you take us through now some of the things now that we've had the ROSC in the patient, return of spontaneous circulation, and we are planning for their post-resuscitation care to enhance and optimize their outcomes. what are some of those key priorities that we have to keep in mind immediately after risk is achieved?
Thank you for that question. Usually during a cardiac arrest, it's quite stressful even for the team, that once you achieve risk, you sort of relax or say a deep sigh of relief. And you tend to forget the very anthem that my colleague Jonan mentioned, that all EMS providers have at heart, and that's the primary survey. So immediately after you achieve risk, please go through your ABCDE. And at each of these moments, for example, at your airway, you're trying to make sure that your patient has a protected airway. If your patient is not able to breathe on their own, for example, in our scenario, you saw how we had to first remove the bag and confirm that the patient is able to make spontaneous breaths or not. And given the fact that they're not able to have spontaneous breaths, we have to support their breathing and continue bagging. Of course, there are some patients who, after you achieve risk, the patient will be able to breathe on their own. So there, you just let them breathe on their own and need support and give oxygen. Yeah. So you also want to, if they're not able to breathe on their own, you might want to insert an advanced airway. It could be an ETT intubation if you are skilled. If you are not, you may choose something as simple as an iGel that we used in our scenario, which is much easier to use and is very applicable in this scenario. So you may also want to use things such as waveform capnography to confirm placement of either your iGel or your ETT, whichever that you have used, to confirm placement and ensure that you're ventilating your patient. So you also want to maintain normoxia, and that means that you're targeting SpO2s above 94 to 98%, and ensure that you're ventilating your patient and you have pneumocapnia, so your titles are between 35 and 45 per patient. So that means that you're also avoiding hypoxia. If you're able to do an APG, please do one as well. When you come to C, you want to ensure that your patient has IV access, which could be via peripheral line, large bore peripheral lines to be exact. And if you're able to use intraosseous access, please do if you fail to get an IV line. If you're experienced and know how to place an IO, go ahead and place an IO and just ensure that you have IV access. Please ensure to use inotropes or vasopressors once you've achieved risk, if need be. And also don't forget to have a 12-lead ECG done for your patient. Amongst the causes that we have, you're looking for things like ST elevation, pointing into a probably a myocardial infarction. And in such patients, you want to link them to coronary angiography interventions or PCI for that matter. So have a 12-lead ECG done for your patient under the C. You always want to have a target for your systolic blood pressure. Once you get IV access, you want fluids running like you saw in a scenario, and you're targeting a systolic blood pressure of more than 100 or a mark above 65. Those are your targets, yeah. So when you go to D, that's you're looking at your glucose, make sure that you have normal glucose measurements, normoglycemia, and also if your patient has convulsions or has seizures, make sure you're controlling with that. Under E, you want to think of things such as temperature. I know previous literature used to emphasize targeted temperature, but right now we are saying just try and avoid the patient having a fever, for that matter. Yeah. And obviously, your disposition, you have to make sure your patient goes to ICU. So make sure that you're in touch with the ICU team to probably dispose of your patient.
Oh, thank you very much, Rebecca. That's a very structured approach to post-resuscitation care. And I think everything brings us back to our ABCDE really. But now we are seeing that in each of those areas and parameters, we do have post-resuscitation goals. So I think the take home here is know what your targets are post-resuscitation and address your ABCDEs to actually meet those targets and meet those goals. So we shall stop the discussion here for now. It's been very enlightening, and we are going into another poll question before we go into our expert session, which is going to be very exciting So let's all look to our screens and answer poll question number 4. And in this question, we do have a case where we have a 60-year-old patient who achieves return of spontaneous circulation after 10 minutes of CPR in the emergency department. What is the most immediate priority? So this is something that we've just been discussing. So post-ROSC care, what is your priority? Do you want to discontinue monitoring? Do you want to provide oxygenation and hemodynamic stabilization? Would you like to transfer the patient immediately without stabilization? Or would you administer prophylactic antibiotics? So please read through the question and digest it, and would like to see your thoughts on that particular question before we dive into the most exciting part of the session today. We have our expert who can't wait to share their insights with the whole audience. Right, lovely. I see a couple of people are answering in the chat. If you would kindly answer the question with the poll directly, just tap the correct answer on your screen and then submit. We'd just like to see what the group thinks. It would be easier for us to track that way. Right, keep the answers coming in. We would like to see what your thoughts are and to see if Rebecca's points hit home regarding post-ROSC care. So what are your thoughts regarding this patient? 60-year-old patient with ROSC after 10 minutes of CPR. So what would you like to do in this situation? Okay, nearly half of the group has responded. A few more coming in. All right, you should see the poll question on your screen. Great. Great, we have some more people answering the questions, and it seems like everyone really understood Rebecca's point from what I'm seeing here. So well done to the group. We shall close the poll now. Thank you for the participation in that. And at this point in time, I would like to transfer the spotlight to one of the top emergency physicians that we have currently, Dr. Daniel Olinga, who is going to give us a brief presentation highlighting ED assessment, investigation, and management, as well as disposition of patients with cardiac arrest. I believe in his presentation, he's going to highlight also a few misconceptions and pitfalls when it comes to cardiac arrest and CPR. And it will be interesting to see some of the common misconceptions people have. I will hand over the mic to him, and Daniel, over to you to take over.
Thank you very much, Chair, Dr. Faith. Surely, if one of my patients went or got a cardiac arrest, and I see the team that simulated for us today approaching this bedside, I would just whisper to the patient to sit back and relax. Unfortunately, at that point, they are already relaxed. And so let's buckle up as we recognize, react, and rescue. Most of the insights towards cardiac arrest management have been highlighted greatly and deliberated by the panel over the other side. And I could only be typing whatever they were saying so that it bolsters the presentation that we have today. And just to check in with everyone, thumbs up if you can see my slides. if that is true for sure, I'll then proceed with the presentation. And this is our scope today. A chain of survival has already been highlighted by the team from the introduction of the session all the way to the discussions that we have been having. We have been emphasizing on the chain of survival. We shall highlight briefly on recognizing a cardiac arrest, the common arrest rhythms that we shall encounter. Reversible causes have been highlighted on. I'll not dwell much on that, and hint on a few pearls and pitfalls for us today. And so buckle up and get your scuba material ready. We are going to have a deep dive and unearth the concepts about cardiac arrest, something that very many people are worried about, and yet it's something that is really easy if we are organized, just like the team that demonstrated for us today. And so this presentation is really based on the ERC guidelines of 2025 that were released recently. And so many perspectives are new, but they emphasize on the previous and also bringing in newer points that are really easy for us to remember. To remind us, we ought to always recognize a cardiac arrest as early as possible, because this increases the chances for us to actually also initiate early CPR. Luckily for us now, the Ministry of Health has a helpline where you can actually call in, and they can link you up to the nearest personnel to actually help dive in to support you. But calling for help in this context means in the setting where you are at and the cardiac arrest has occurred, shout out for those who are around you so that they can help you with a thing or two. They say more hands are better than a few. And so Dominic emphasized on early CPR and its qualities. Early defibrillation was also mentioned, and in the chats I saw people debating about the AED and the manual defib. We shall discuss that further as well. And then the advanced care team shall surely not lose it. The advanced care team shall surely be on board, and that is those who are trained to deliver the advanced life support. And then you also have to plan for rehabilitation and support. That is where you are going to dispose your patient off to. Someone is writing on the screen, so if we can
You can proceed, Daniel. Someone is addressing that. Sorry about that.
all right. And all right, so thank you very much, Faith, for addressing that issue. I hope my slides are moving. If they are, please tell me. So moving on from the chain of survival then, we go on to recognizing cardiac arrest. And so just like Simon, who was the team lead here, approached the patient bedside, you have to assess for unresponsiveness. And here you have to shout out the patient's name by voice, but also inflict some pain on the sternum by virtue of a sternal rub. And this you are assessing for responsiveness. And for the 10 seconds that were clearly and loudly elaborated, you are palpating for the pulse, going closer to the carotid, open the chest to look out for chest rise. If there is none of those for 10 seconds, then surely your patient is in a cardiac arrest. And so you ought to call for help as soon as possible. And as you're shouting out for help, your hands are already diving down onto the chest and starting the CPR. Something about agonal breathing is a patient who is trying to swallow air, if I can mention it in words, but demonstrating is he's taking in those shallow breaths, but in a more prolonged manner, not an actual breathing, like he is swallowing air in there. That's agonal breathing, and that's a sign of a cardiac arrest. Do not wait to do your ABCs again. Some people want to rush through, how is my airway, is it patent, to start putting on the BP cuff, etc. But at this point, this patient is in a cardiac arrest. Agonal breathing is not a sign of life, so treat it as an arrest and start CPR immediately. Put for you an additional note there for dispatcher CPR, assisted CPR, and I'll highlight that more later about the bystander. One big myth that we always encounter is in many settings, fixed dilated pupils mean the patient is dead or unsalvageable, and which is a lie, because the fact is that dilated pupils occur within 15 to 30 seconds of a cardiac arrest. And this is normal physiology because there is already hypoxia that is starting to set in. Limited oxygen is reaching the brain, and so these pupils are starting to already dilate. Adrenaline, atropine, and other sympathomimetic or stimulant drugs can actually cause you fixed and dilated pupils. In one of our reversible causes, especially in the T's, we looked at toxins or overdoses of drugs, and some of these drugs can actually manifest that. And so some people may stop or do not even start CPR because they're using the pupil. Please do not rely on that. Pupils never decide whether you should start or continue CPR. And once you've successfully gotten return of spontaneous circulation and you have addressed your reversible causes that you identified, surely your pupils will get back to that normal reactive reaction, the PAL that you always mention in your examination. And so moving on to the cardiac arrest rhythms, there are 4 major rhythms. I moved across the country, and this one monitor is from Nyumbe, another is from Valley Regional Referral. So these are real-time patient monitors, and this, unfortunately, on those visits, somehow cardiac arrests were occurring. So cardiac arrest rhythms are categorized into 4. There are 4 examples for those, but they are broken down into 2. So the shockable and non-shockable rhythms. I'll dive into detail, but as you look at the first one there, which is the ventricular fibrillation, the waves moving all over the place, not organized, disordered. Then on your right of the screen, you're seeing something more organized, but when you palpate for the patient pulse, it will not be there. And so we consider this to be the pulseless ventricular tachycardia. For the non-shockable rhythms, we have 2 in adults majorly. Asystole, which is a flat line. And then we also have a pulseless electrical activity, where you actually have activity of the heart. But when you palpate for the pulse on the patient, it's not there. And so before we confuse ourselves about these rhythms that are shockable and non-shockable, here is just a sneak peek into what a normal ECG tracing would look like. It would have a P wave represented as P there. It would have this broad QRS. So this item that you see in the middle here. And then after you will have a T wave. So this pattern repeats itself with another P, QRS, and then T. And this is what you want to look out for a normal rhythm, at least one that is compatible with life. There are very many other arrhythmias that may occur, but this is what I want you to harness first. With this in mind, that we're having a clear P wave popping in there, QRS and T, let's dive into the nitties of these rhythms. So the first arm is the shockable rhythm, which is ventricular fibrillation and pulseless ventricular tachycardia. So the ventricular fibrillation, these are really irregular rhythms that you will encounter. They can be coarse, which means really big, or fine, tiny waveforms moving within that baseline. they are chaotic all over the screen, and the monitor itself, because they normally have that sounds, will be beeping for you in an irregular manner. And so use your ears and your eyes to actually try to fit this pattern. And like we relate to the normal ECG strip, it will have no P waves, definitely, and it will not have T waves. On the other hand is the pulseless ventricular tachycardia. For those who know soldiers who are marching, they tend to be uniform in their marching. So this is regular, it is wide complex. You will also not discern the P waves and the T waves clearly, but at least to differentiate the pulseless ventricular tachycardia from the fibrillation is regularity. VTAC, regular, VFib, irregular, very high rates. And to add that for the ventricular tachycardia, there is no pulse when you palpate for the patient's pulse, because sometimes they can actually have this rhythm and there is a pulse. So that is not cardiac arrest. For the non-shockable rhythms, we have the assistor and PEA, like I'd highlighted for you. Flatline, very common in movies. Whenever you're seeing a medical series, they will bring for you something close to a flatline, assistor, and everyone is diving onto that chest. So that is very easy. Do not shock, do not deliver any energy. And on the other arm is the pulseless electrical activity. You will see some patterns that are mimicking what is close to normal, or something above the baseline, like the heart is beating somewhat, but when you palpate, there is actually no pulse. So we consider the pulseless electrical activity, and they are non-shockable rhythms. Another person will say, what about in the pediatric population? There are 3, and we add bradycardia to it, which is heart rate below 60. This was highlighted by Dominic for spaced repetition, high quality CPR in numbers. So what matters most? Heart rate should be around 100 to 120 as you're compressing. Your depth. I was very happy to see Dominic's arm pushing in nicely, 5 to 6 centimeters. Some people are really mugged and they move from the sternum and they make the sternum communicate with the vertebral column, vertebral bone and etc. That is dangerous. You're compressing below 5 to 6 centimeters. So remember 5 to 6 centimeters. Train that whenever you can. And then a ratio of 30 to 2. When you're not in an advanced setting where you do not have intubation modalities, perhaps you're down there in a Molatar and there is no iGel or LMA supraglottic device, you will secure your airway if you have an oropharyngeal airway. And then with the chest compressions of 30, you give 2 breaths to that. Then the chest compression fraction, that is, you should achieve something greater than 60. What does this mean? For instance, in a 10-minute mark of CPR, we want to achieve at least 6 minutes of compressions in that. The other 4 minutes could be because of the delays of assessing for rhythm, the delays of shocking. That is where we interrupt. So if you translate that to a percentage, it is above 60% of chest compression fraction. Pause time should be less than 10 seconds, and then adequate tidals for a normal physiological adult should be 500 mils. That is, those bags, BVMs, have their different volumes, but you just want to achieve a volume of about 500 mils. And as you're doing this, please allow for that chest to recoil. This is what the heart also does. It beats with bits of relaxation in it there. So if you don't allow for it to refill, then you are not doing the best in delivering chest compressions. So there are people who rest over the chest, and that does not help much. And also remember, just like Jonan and Dominic were doing, they kept on switching because there is fatigue that occurs when you're doing chest compressions. So let's get into the algorithm. Luckily, we already handled one algorithm in the scenario, and that was for the shockable rhythms. And our shockable rhythm was ventricular fibrillation, but it could also be a pulseless ventricular tachycardia. You've assessed your patient and you've actually recognized that the patient is in a cardiac arrest. Shout out for help and immediately start CPR at a ratio of 30 to 2. attached defibrillators for those in very fancy settings, but in most settings, the government has supplied defibrillators with paddles. So you will have to pull out those paddles and assess your rhythm. The caveat is here. Once someone is compressing, the defibrillator will actually be picking the compressions. So you ought to tell the compressor to pause as you're assessing the rhythm, because that is when you will actually get the true rhythm for which the patient is on. And so if it is shockable, deliver a safe shock, as like Mildred did. And the shock energy you want to use, I saw a comment in the chats. There are two forms of defibrillators, biphasic and monophasic. The safety net here is just say select maximum joules. For biphasics, maximum will be 200, and for monophasic, 360. People who are lazy, I call them lazy, but it happens in pre-hospital or petrol stations. You don't have a defibrillator. There is an AED. This one talks to you. It tells you what to do, tells you stop, attach pads, and assesses the rhythm for you and does the needful. You just ought to follow instructions. Once you've delivered your safe shock, immediately resume the chest compressions. After 2 minutes again, you reassess your rhythm. Still shockable, deliver another shock. And after the third shock, if you're still in a cardiac arrest, give adrenaline like the team did, 1 milligram, IV or IO, depending on the access you have, and amiodarone, 300 milligrams IV. Repeat adrenaline every 3 to 5 minutes. So the safest here is saying every 4 minutes. That is easier to track. And if you have a scribe, it's easy to actually ask them at what point are we on. So every 3 to 5 minutes, give adrenaline. But after the fifth shock, give amiodarone, but this time you've reduced the dose to 150 milligrams. If amiodarone is not in your setting, please consider cardiac lidocaine and give it at 100 milligrams IV. Until you achieve return of spontaneous circulation, you can repeat the sequence, and we shall tell you when to stop later. And so these are some of the defibrillators you may encounter in the streets of Uganda. Some hospitals will actually have this fancy Mindray here. I know where Faith works, they have this near exact one. And then there's also an AED machine that talks to you. You just have to open, follow the prompts. And for the non-shockable rhythms, here it is all things CPR and adrenaline. Identify if it's a PEA or a systole, just like I highlighted earlier. If the patient is in a cardiac arrest and you've seen those rhythms, continue CPR at a ratio of 30 to 2 and immediately give adrenaline. Adrenaline is then given every 4 minutes. So you give now, rest in the next, and then repeat adrenaline again. As you're doing that, between those 2 minutes, you're actually assessing for reversible causes, like Simon elaborately delivered it, the 4 H's and the 4 T's. Continue this, but if you see a rhythm changing to a shockable rhythm, that is ventricular fibrillation or pulseless ventricular tachycardia, then surely switch to the shockable arm. I will not delve much into the reversible causes. We know it's hypoxia now, which is the most common reversible cause, hypovolemia, hypo-K or hyper-K with other electrolyte disturbances in there, including acidosis and also glucose. And then hypothermia is another. Patient is not dead until warm and dead. That is the caveat you need to always remember. These are the 40s, tension pneumothorax, which is the commonest in trauma. There's cardiac tamponade, toxins, and thrombosis, which could be a PE or an acute coronary syndrome with a STEMI in there. You'll get the slides and read better on this. So the questions that I was asking myself when we put out this call is that commonly people ask, when do we start CPR? We have now known that we start CPR when the patient is unresponsive, there is no pulse, and they are not breathing. We've also said they're having agonal breathing, or they're having those gasps or swallows that we may say that actually classifies them to be in a cardiac arrest. They do not have in other countries outside there is actually do not attempt CPR. So if that order is not there and the patient gets into a cardiac arrest, please, you're liable to starting this CPR so that you resuscitate the patient. If you have witnessed a collapse, or it was just briefly, nurses sometimes, I was just giving IV fluids and the patient suddenly collapsed. Less than 2 minutes, please start the cardiac arrest. If it was a nurse or an attendant who said it was brief, just a few minutes ago, start it. And then if there are no signs of irreversible death, rigor mortis, liver mortis, or recently we had someone who had just started advanced life support. The patient had come without the head and he was doing CPR. So the head is already missing. Why are we doing CPR? But it happens because some people get excited because they have a skill. Do not delay CPR just because you want to confirm a pulse. If you're not sure, start CPR. The patient will push your hand if they're actually alive. They have the energy too. When not to start CPR? Possibly a direct opposite of what we have just been talking about, but well, do not attempt CPR order is there and it's a directive from court as well. That does not permit you to start. And if you've started and then it comes in later, please, you can always stop because there was an order. There are clear signs of death that this is irreversible. Someone was even exhumed from the grave, but because he has been brought by police, for you want first attempt CPR, the guy is already in rigor mortis. Don't start CPR from in that case, really. Clinician safety as well. So a flat is falling, you're going to rescue, and then you're palpating, but above you there was a certain pavement or a paver that is actually going to land on your scalp as well, and you become a casualty. So even in this case, we need to protect the health worker. You rather lose one and save many in future. But yeah, in cases of stampedes and etc., you have to be on the lookout. When to stop CPR? This is another key question that keeps coming up. Stopping CPR is not an individual decision because some people can use feelings to actually say, nah, I'm tired. Especially if the team leader wants to go somewhere, they stop CPR because of that. But we say no. This is a team sport. Is it a sport? No, but we work as a team. And so it's a team effort to actually say, perhaps with A, B, C, D, and E, we need to stop CPR. So one, like our team did today, return of spontaneous circulation. Everyone will high five and say, yeah, our patient is back to life. Please do not dive on the chest again and continue compressing the chest. Prolonged normothermic arrest. So these are warm patients. And the time here is greater than 20 to 30 minutes without return of spontaneous circulation. You have done your thorough assessment of the 4Ts and the 4Hs. You've intervened in a timely manner, but over these 20 to 30 minutes, patient has been hot or warm, do not continue. Please just hold back. Rescuer exhaustion, this happens largely in a pre-hospital. You will see that there's a driver and maybe a paramedic in there, and they are starting CPR. You get fatigued because if you've not gotten support coming to you, then definitely you will have to give up and say, no, we have not gotten any risk and we are going to get tired. You will be lying to yourself that you're doing in a CPR. All right, and then if there is a asystole, persistent asystole, so first rhythm is asystole, another is asystole for over 20 minutes. Again, at this point, please do not continue CPR, just stop CPR. But it's important to involve the family every step of the way. Inform them why you are actually stopping the CPR. We have done our best and be compassionate enough. We are going to stop this resuscitation, and then you clearly document the death. Of course, I'm presenting and speaking, I'm more compassionate than that. And you be sorrowful and empathetic to this family that have lost a dear one. When do we prolong CPR? Again, there are special scenarios. One is hypothermia. You start your CPR with a core temperature of less than 30. Remember, the patient is not dead until warm and dead. So you want to rewarm the patient to actually levels of 35 degrees. And in a fancy setting, you may have an ECMO, that is a bypass that helps you in oxygenating, but also rewarming this blood. When you achieve 35 and the patient is still not getting ROSC, then you can call them dead. Patients who have drowned or submerged in very cold waters as well, this ties up with the hypothermia. Please try to rewarm these patients. Do not give up early. Till they are 35 degrees, you can actually call for end of CPR in case you have achieved that. Overdoses. History was emphasized by the chair, Dr. Faith. And so if you have identified that this patient perhaps had benzodiazepines, diazepam overdose, and etc., you know the antidote to this. Give the antidote time to actually reverse the effect of the drug. We have local anesthetic systemic toxicity. Lidocaine gets into the system, patient gets cardiac arrest. Run for your lipid emulsion. You can extend this beyond the 30-minute mark to at least 1 hour, 60 to 90 minutes, because you want to give the antidote time to also function and work in that case. Then thrombolysis, patients who have PE, once you've administered the thrombolytic, again, give the thrombolytic time to actually break down the clot. So you'd also extend for those. And patients who have access to this, a young patient, you witnessed the cardiac arrest, yes, you did not get ROSC, you may want to give them a chance. And so pediatric populations, because we know their reversible causes tend to be lingering around hypoxia, hypovolemia, hypoglycemia. So put them in an ECMO machine and attempt to continue for another 30 minutes to make it 1 hour. Well, the team are highlighted on the drugs, and I'm not going to delve much on this. You will get to read this when you get the slide with you. For the adrenaline and amiodarone, especially for the shockable arm of the cardiac arrest. Other drugs that may be employed in resuscitating the patient, I already earlier on alluded to the cardiac lidocaine at 100 milligrams. Give it IV as well. Give it at the intervals like you would give for amiodarone. Another is sodium bicarb, which is a controversial drug. People tend to run for it very early, but it works hand in hand with ABGs. For instance, if you have very bad or severe acidosis below 6.9, you would want to temporize the environment, the acidic environment, to allow for the heart to actually function better. So you would want to give sodium bicarb. It comes in handy in tricyclic antidepressant overdoses like amitriptyline. You can actually give sodium bicarb. It's an antidote for that. It reverses its actions. Then some drugs are specific to the cause of the cardiac arrest. For instance, the calcium chloride helps us in reversing hyperkalemia. If you have hypocalcemia, you're introducing calcium into the system. And also for calcium channel blockade, you may still be introducing calcium. So that's specific to that reversible cause as well. Then there are specific rhythms that may appear in RS, like torsade de poids, twisting of points, which may also be coupled with hypomagnesemia. Here you can get magnesium sulfate, 2 grams, reloading. Now the new guidelines are very clear and specific that we no longer recommend the use of atropine. Many people run for atropine, but it is doing nothing to your body. Better yet, if your patient is about to get ROSC, you might send them into an anticholinergic toxidrome because you were over administering atropine. So we no longer recommend the use of atropine. Pre-hospital, load and go. That is our motto. We are advocating for the Lucas device to come through. This is a robotic machine that is trained to deliver good quality, high quality CPR. And we can employ this in an ambulance. But now imagine the setting of Uganda. We do not have this Lucas device. You have 1 paramedic and 1 driver transporting this patient who has gotten a cardiac arrest. When I was unearthing this information, many settings that employ this, you realize one hospital is in Yumbe, And then the nearest referral center is perhaps in Kampala. So that distance is very long. Luckily for us, we have very many sub-hospitals there. You're traveling along the journeys to Lira, but you have Chirandongo somewhere there. There's Nakasongola, Luero. So you have very many opportunities to actually branch to that place while you've initiated your BLS and get more people to actually help you than insisting to do CPR because you want to reach Women's Center in Mulago. That does not help us much. And also, you target to go to centers that have ECMO machines. So what are we emphasizing here? Avoid doing procedures that are going to delay you initiating your CPR, looking for the lines, attempting to put your IG and you're not successful. Then you're trying to do CPR when you're on a stretcher. The thing is soft, so the body is just moving with the softness of the stretcher. So you also look out for that. Okay. Fast forward onto the traumatic cardiac arrest. We shall not dwell much onto this, but you need to deal with the reversible causes simultaneously. Hemorrhage could be ongoing. Please replace the blood loss that is ongoing. Give fluids as well. This patient could be having troubles with hypoxia, and yet it could be from attention pneumothorax. You're encouraged to have a bilateral finger thoracostomy in the ED, but pre-hospital, you can do a needle decompression bilaterally. So all these reversible causes can actually occur in a patient who has trauma, all the way from hypoxia, hypovolemia. Because of crash injuries, they are exposed to hyperkalemia. Because they're losing a lot of blood, they can become cold. Then on the other side, you have tension pneumothorax. They could be having cardiac tamponade. They could have thrown an emboli up there, fat embolus. And then toxins, combustion, you can have cyanide toxicity. All these in trauma can be considered. And you need to be very accurate with your team while trying to handle that. Post-cardiac arrest care was really handled nicely, and the targets are really achieving the normal ranges. For every target that we have, we want the normal ranges. Target map above 75, especially for the brain. Avoid systolics below 90, so you want things above 90. Hence, what modalities will you employ to achieve that? You want vasopressors in there. Also do your 12-lead ECG. Oxygenation, the targets are 94 to 98. Avoid over-oxygenating or giving too much oxygen because you may also result into production of oxygen-free radicals. So that is another crucial point that you need to keep close to you. Then the targets for respiratory rate is 10 to 12 breaths per minute. Keynote, when you're doing the post-cardiac arrest care, you need to be in communication with the ICU team because they are the ones who are going to advance this care. For instance, vasopressors, they need to use infusion pumps and monitor closely, titrate to the patient's response, intubating them and connecting them to the machine. Again, it's the advanced ICU team that needs to do that. Neuroprotection is an emphasis that we also have, and the temperature that we target again is normothermia. So we want 36 to 37. Targeted temperature management may be done for the first 24 hours, but we are rushing to achieve the normothermia because that is where the metabolic processes of the body are really at norm. And so briefly, here are the ICU goals of management. Everything needs to be achieved within normal, but emphasis here, early rehabilitation of this patient. Once they're out of the arrest, you start them from the time you're doing post-cardiac arrest. And also family communication is very important. Keep updating the family about the progress of their patient. So onto the pulse. A lot was mentioned, and so POCAS is very important, especially for tamponade and teasing out thrombosis. And then end-tidal carbon dioxide is also important in you recognizing that you have return of spontaneous circulation. For young patients, you tend to go a little longer with them. Patient is not dead until warm and dead. Pitfalls, I already talked about the pupils. Pupils do not determine whether you should stop or not start CPR. Many times, again, people tend to delay reinitiating CPR beyond 10 seconds. Please remember that you need to keep within the 60% of chest compressions. And then if you do not have a team leader assigned and there are no clear roles, be ready for chaos because people will be all over the place. Everyone will assume or not assume a certain role that is being given unto them. Team dynamics were highlighted a lot, and many people ask, how many team members can I have? 5 to 6. And here are the roles that you can actually have when you're trying to allocate these roles in your team. And closed loop communication is key. Clear name, what task you've given them. Hey, John, give adrenaline 1 milligram now. John replies, adrenaline 1 milligram, given for clarity of closed loop. And so with that rampage of events with spaced repetition in there, the 5 key takeaways for today is that act fast. So immediately recognize the cardiac arrest and initiate early CPR and early defibrillation. You need to emphasize high quality chest compressions with the parameters of chest compressions clearly known there. Find the cause. Do not dwell on one cause. You spend 2 minutes singing about hypoxia and hypovolemia. You have 4 H's, 4 T's. Have a clear system for which you're going to address those. And then know your algorithm. We use largely the ERC algorithm. And so it guides you on which arm to take once you've actually identified the index rhythm. ROSC is not a finish line. Remember, post-arrest care is very important. This is the time many patients re-arrest. And when they re-arrest, the chances of not getting ROSC actually increase. Thank you very much for listening. Over to you, Chair.
Been a very wonderful presentation and very enriching. I'm sure we've all learned a lot. It's been beautiful, really. And you have tackled all the objectives that we set out to address today. I would say that at this point, we are actually short of time, unfortunately, and we will not be able to delve too much into the Q&A. I know that a couple of people needed to unmute and talk about some pressing issues. We shall leave that to our emergency medicine expert in the chat to address. So Dr. Sarah will do her best to answer those questions. Unfortunately, we won't have time for that because we are out of time. Now, on your screens right now is a post test that we would request that you answer just to show what you learned and help us to know how much you were able to gain from the session. I would request everyone to fill in that poll, fill in that post test. Would be very glad if you do that. As that happens, we shall start to conclude the session. First of all, just to summarize what we have been discussing today. So today, like we set out to do, was for us to learn how to recognize, react, and rescue. So number one is we wanted to ensure everyone knows how to recognize a cardiac arrest. Number two, we wanted everyone to be able to know how to initiate early chest compressions. Number three is we wanted everyone to know how to give, to recognize a rhythm and then to be able to also give safe defibrillation. Number four, we wanted everyone to be able by the end of the session to know how to identify and address the reversible causes of cardiac arrest. And finally, we wanted everyone by the end of the session to know what post-resuscitation care is, what it entails, what are the goals, and how do we improve outcomes of patients that arrest. So I hope this has been a very fruitful session. You've been wonderful in your engagement with the poll questions, with the chats and the questions, and I hope everyone will walk away from today a better emergency care provider than they came before the session. So thank you all for joining. Please go ahead and take part in the post test.
Just wait. Yes, hello team. most of the questions in the chat have been handled, and others have also been handled through the Dr. Daniel's presentation, which was very, very rich and very elaborate. Thank you.
Completely agree. Thank you, Sarah, for the great job in the chat. And just keep looking around if there's any question that pops up as we close. Do assist us to address that. And thank you once again so much. Thanks everyone for joining today. It would be great as we close, just to remember how amazing the group and the session was. If you are able to turn on your video, please do so. We'd like to take a screenshot to remember everyone who was able to attend this session. Would be great to have your faces on the picture. So please turn on your videos if you can, and just give us a big happy smile. That's more like it. Yeah, those are the smiles we're looking for. Lovely. Thanks, everyone. Wonderful, wonderful smiles. Amazing. Thank you all for joining. It's been a pleasure. Thank you all. So as we close, we shall just display for you the answers to the poll questions. We are not going to go into details because we've already had a lengthy discussion on that, but just for you to see what the correct answer was, we are going to display the answers for you on the screen. Right, perfect. Thanks everyone, and cheers. Have an amazing weekend.
Cheers.